Esophageal motility studies using a manometer are performed to measure the competency of the lower esophageal sphincter and the muscles of the esophagus. Motility, manometric, study. The physician inserts a thin tube with pressure sensors, manometer, into the patient's nose or mouth and down into the stomach to perform an esophageal or gastric or duodenum motility study. The muscles of the esophagus/stomach/duodenum and the gastroesophageal/gastroduodenal junction which propel food and water into the stomach, are studied to measure the pressure of the contraction waves and diagnose abnormalities in the esophageal muscles that affect swallowing. Esophageal motility, manometric study of the esophagus and/or gastroesophageal junction, study with interpretation and report. With stimulation or perfusion, e.g., stimulant, acid or alkali perfusion. The tube is slowly withdrawn and stopped at different points along the esophagus. The patient is directed to swallow a little amount of water at each stopping point and the contraction wave pressure and swallowing action are measured and graphed.
Report 91013. In addition to the motility study code, when the motility study is combined with stimulation and/or acid or alkali perfusion. Using a second catheter inserted through the nares, a probe is placed in the distal esophagus and the perfusion substances are introduced. The patient is again directed to swallow at given intervals in order to record additional pressure measurements. The catheter is removed and the information saved for interpretation. Gastric motility, manometric, studies. Duodenal motility, manometric, study. Sensors on the tube measure the amount of pressure generated by the stomach muscles as food is moved into the small intestine. The tighter the muscles contract around the tube, the greater pressure that is sensed. The data is recorded for computer analysis. Esophagus, acid perfusion, Bernstein, test for esophagitis. Both hydrochloric acid and an alternate saline control solution are infused one after the other via a nasogastric tube, without the patient being aware of the identity of the solution. Esophagus, gastroesophageal reflux test, with nasal catheter pH electrode, S. Placement, recording, analysis, and interpretation. The physician performs a gastroesophageal reflux test using esophageal pH electrode placement and recording. A small, thin probe, or electrode, that measures the pH, acidity, level within the esophagus is affixed at the end of flexible nasal catheter tubing. The catheter is inserted through the nose down to the target area in the esophagus, usually determined by manometry, and connected to a data recorder. The probe records the pH level. The catheter/tubing is taped behind the ear and out of the way under clothing, and connected to a small data recorder that is worn around the waist. This code includes the analysis and interpretation of the recorded results. Esophagus, gastroesophageal reflux test, with mucosal attached telemetry pH electrode placement, recording, analysis, and interpretation. The physician performs a gastroesophageal reflux test using mucosal attached telemetry pH electrode placement and recording. A small capsule containing a radiotelemetry pH sensor is inserted endoscopically in the esophagus and temporarily attached to the esophageal wall. The capsule monitors esophageal pH levels over a 48-hour period. This information is transmitted to an external pager-sized receiver worn by the patient that records pH levels. After the 48-hour testing period, the data is downloaded from the receiver to a computer that contains software for analyzing pH levels. The physician provides a written interpretation of the computer analysis. The capsule does not need to be removed as it spontaneously detaches within 7 to 10 days and passes through the digestive tract. Esophageal function test, gastroesophageal reflux test with nasal catheter intraluminal impedance electrode, S, placement, recording, analysis, and interpretation. Prolonged, greater than 1 hour, up to 24 hours. The physician performs an esophageal function test with gastroesophageal reflux testing using nasal catheter intraluminal impedance electrode placement and recording. The patient fasts for a minimum of 6 hours. An impedance probe affixed to flexible nasal catheter tubing is inserted through the nose down to the lower esophageal sphincter following location of the lower sphincter by manometry. The impedance probe contains several electrodes that make up multiple measuring segments each 2 cm in length. The measuring segments are located at intervals above the proximal border of the lower esophageal sphincter. The patient is given a liquid or solid bolus to swallow. As the bolus passes through the esophagus, the average electrical resistance between 2 adjacent electrodes, impedance, is measured. The electrodes detect esophageal contraction and expansion and movement of the bolus through the esophagus in real time, as well as any gastroesophageal reflux. This test is also referred to as multichannel intraluminal impedance testing or MI. Esophageal balloon distension study, diagnostic, with provocation when performed. The patient fasts for a minimum of 6 hours. A local anesthetic is sprayed into the patient's throat. With the patient in an upright position, a probe is passed through the mouth into the esophagus. The subject is placed supine with the head of the exam table elevated approximately 30 degrees. Manometric pressure recordings are obtained to identify the upper and lower esophageal sphincters. The probe is removed and the physician inserts a balloon into the esophagus. The balloon is moved along the esophagus and inflated multiple times to increasing diameters at selected sites in the esophagus in an attempt to provoke chest pain in the patient. Breath hydrogen or methane test, e.g., for detection of lactase deficiency, fructose intolerance, bacterial overgrowth, or orocecal gastrointestinal transit. At the start of the test, a sample breath is taken. The individual blows into and fills a balloon with a breath of air. The concentration of hydrogen or methane from the sample breath is removed from the balloon and measured. The individual ingests a small amount of the test sugar, lactose, fructose, lactulose. Samples of breath are collected and analyzed every 15 minutes for 3 to 5 hours. Gastrointestinal tract imaging, intraluminal, e.g., capsule endoscopy, esophagus through ileum with interpretation and report. Esophagus with interpretation and report. Gastrointestinal, GI, tract imaging from inside the lumen of the intestinal tract is done in a non-invasive manner by capsule endoscopy. The patient is required to fast for 10 hours before the procedure. The patient swallows the endoscopic capsule with a glass of water. Color video images from inside the GI tract are recorded as the natural peristaltic movement passes the capsule smoothly and painlessly through the system. Sensors are secured to the patient's abdomen and worn like a belt around the waist, allowing data from the capsule to transmit to a data recorder while the patient goes about daily ambulatory activities. After 8 hours, the patient returns the equipment for processing at the computer workstation. The images are reviewed, interpreted, and a report is prepared. Gastrointestinal transit and pressure measurement, stomach through colon, wireless capsule with interpretation and report. Gastrointestinal, GI, transit and pressure measurement are performed via wireless capsule. The patient swallows the capsule with a glass of water. Pressure, pH, and temperature are recorded as the natural peristaltic movement passes the capsule smoothly and painlessly through the system. This information is used to calculate regional transit times, including gastric emptying time, small bowel transit time, colonic transit time, combined small/large bowel transit time, whole gut transit time, pressure contraction patterns from the antrum and duodenum, and motility indices. The data is transmitted from the capsule to a data recorder, worn like a belt around the patient's waist or around the neck, while the patient goes about daily ambulatory activities. The equipment is brought to the provider for processing at the computer workstation. The images are reviewed, interpreted, and a report is prepared. Colon motility, manometric, study, minimum 6 hours continuous recording, including provocation tests, e.g., meal, intracolonic balloon distension, pharmacologic agents, if performed, with interpretation and report. Colonic motility is measured using various manometric techniques. In one method, a manometric catheter is positioned endoscopically and clipped to the colonic mucosa. A minimum of 6 hours of continuous recording ensues. Any provocation tests performed are included, as is the interpretation and report. Rectal sensation, tone, and compliance test, i.e., response to graded balloon distension. The physician performs a rectal sensation tone and compliance test using graded balloon distension to evaluate anorectal pathology. Tone tests for relaxation or rigidity in the rectum. Compliance tests the distensibility of the rectum. Sensation tests for fullness and discomfort upon distension. The patient is asked to empty his or her bowels. The patient is placed in left lateral decubitus position with the head lowered 20 degrees. The physician inserts a 2-lumen catheter containing a cylindrical bag into the rectum. 1 lumen is used to inflate the bag, the other is used to measure pressure within the bag. With the distal end of the bag 5 cm from the anal verge, the bag is inflated with air. Inflation is slowly increased and sensation, tone, and compliance monitored. The balloon is deflated when the patient experiences discomfort and urgency lasting more than 30 seconds. Anorectal manometry. The physician performs anorectal manometry to help in diagnosing constipation and/or incontinence due to myotonic dysfunction or suspected cases of Hirschsprung's disease. Hirschsprung's disease is a congenital absence of ganglion nerve cells in the plexus that innervates the colon and/or rectum to relax the internal anorectal sphincter in response to rectal distension. A manometry probe is advanced into the rectum after a digital exam. The probe is slowly withdrawn, taking continuous pressure measurements until the high pressure area of the anal sphincters is located. With the patient relaxed, the basal anal pressure is recorded, and highest pressures are recorded as the patient performs a maximum squeeze. The manometry catheter is inserted again with a rectal balloon that is slowly inflated to the patient's first sensation of fullness and the volume is recorded. The anal sphincter response to the rectal distension is also recorded. Electrogastrography, diagnostic, transcutaneous. With provocative testing. In electrogastrography, electrodes are placed on the skin over the stomach at a specific distance from each other and attached to a recording computer. Report 91133. When diagnostic egg is performed in conjunction with the administration of a drug in an attempt to manipulate conditions and provoke a measurable abnormality. Liver elastography, mechanically induced shear wave, e.g., vibration, without imaging, with interpretation and report. Liver elastography is a non-invasive procedure for assessing liver stiffness, beneficial in determining the amount of fibrosis and scarring of the liver due to damage, and may also be used to survey any disorder advancement and help evaluate ongoing therapy. A probe is applied to the skin between the ribs, focusing on the liver. The shear wave is mechanically generated, causing the probe to discharge pulses that meet the shear wave and bounce back to the probe. This process allows the shear wave to be measured, which leads to values for liver stiffness. This code indicates no imaging, however, interpretation and report is required. Unlisted diagnostic gastroenterology procedure.